All right, guys, so today we're going to go over chapter 20, or I'm sorry, module 20, module 21. So those are both from your Neild and Gehrig book. And then we're going to go over chapter 30 from your Darby and Walsh book. So a lot of what we're talking about today is periodontal instrumentation. So working on those patients who do have deeper pockets and you're getting into trickier areas, and a lot of your tooth morphology is going to come back into play. So we're going to start with module 20, which is the specialized periodontal instruments. So the first ones we're going to talk about are periodontal files. So a periodontal file is used to prepare calculus deposits before removal with another instrument, which is typically going to be some kind of a Gracie, maybe a universal curette. It's used to crush or roughen a heavy deposit, so it can be removed with a sickle scaler or a curette or a Gracie of some kind. Files are limited to use on enamel surfaces or on outer surfaces of calculus deposits. And the reason for that is just because the way you use a file is so different. You're almost kind of just dragging it across the calculus. And if you drag it directly across the root surface, then you could cause some damage to the root. Files are used in sets, so there'll be a buccal lingual and then a mesial distal. And so you need both instruments in order to be able to use it on all surfaces of the teeth. But typically this is something that you're using only localized, maybe on like one really tough piece of calculus. Periodontal files are great for burnished calculus, especially, or really tenacious deposits. Just kind of helps you to crush it up so that you can get in there and really get it off. So they have a series of cutting edges lined up on a base. The shank is rigid and transmits little tactile information for the clinician's fingers. So this is something like you're not going to be doing a lot of feeling with your files, like how we talk about kind of doing an exploratory stroke with your instruments before you make a working stroke. Your files are something that you're going to have to feel with your Explorer and then just get it in the same spot and then do some working strokes across the calculus. And so the face of the working end should be flat against the calculus deposits because the cutting edges are already angled so that the corners of the cutting edges did not gouge the root surface or the soft tissue. Okay, so that's really important that we're just right on top of the calculus deposit. And then adaptation of the working end to calculus or to a calculus deposit and resting the lower shank against the tooth. Okay, so this lower shank at the bottom here should be resting because the root surface is going to be a little lower. So basically we just don't want this shank way out into the tissue. That's the most important thing. We want it to be almost parallel with the tooth surface. Okay. 2 points of contact, so this is just showing that the lower shank is right up against the tooth, and then these lower cutting edges are flat against the calculus. Like I said, we just don't want this lower shank hanging too low down here because then you're going to be pulling at the tissue, okay? When you're using a periodontal file, most times your patients are going to be numb, but it's still important to be able to not cause tissue trauma. That way, when the numbing wears off, they're not going to be as sensitive. And we also just want to maintain the tissue intact as much as we can, okay? So this is like the same image that we had for all of our instruments in the Neild and Gehrig book, that it's like color-coded for what surface you're going to use it on. So you can see how like this yellow and orange one is going to be our mesial distal, okay? And then this purplish and teal are going to be our buccal lingual, okay? And when we have periodontal files in the clinic, you guys will not be issued periodontal files just because it's something that you really don't use that often, and we didn't feel like it was important for you guys to purchase them. Honestly, the office I worked in, or that I work in, like there was not periodontal files there when I got there. And like I have one set from school that's in the drawer, and I think I've used it one time in the 4 years that I've been there. So it's like, just using that. It's important to know how to use these, and some of you are really going to like them. And others of you will probably never use them. That's kind of how these specialized instruments work. Just like how some of you really like Gracie's, some of you really like your universals. It's going to be clinician preference here. But it is important for you guys to know how to use them. So then there's one double-ended periodontal file for the facial and lingual of the anterior. So it's just showing you there, facial and lingual. And then this is just telling you, these were used a lot, guys, before we had ultrasonic instrumentation, because clinicians didn't have a way to like break up those big deposits. And so they would use files to break it up. But now, I mean, this isn't near as efficient or effective as the ultrasonic scaler. So yes, they're great for some patients, not an everyday kind of thing though. Okay, so like we talked about, it's a set for the posterior teeth. We already talked about where you're going to use them at. They're called Hirschfeld files is one brand. There's a 3.7 and a 5.11. So this is just, again, showing you what surfaces are which. Again, it's going to be buccolingual, mesial, distal. It's really easy to tell which is the working end because one end is going to be smooth, one end has the cutting edges on it. So it's super easy. So this is just showing getting ready. You're going to insert beneath the gingival margin to where you're right on top of the calculus deposit. We're going to establish that 2-point contact, okay? And then you just activate a pull stroke. So you're basically just dragging it right over top of the calculus. For the lingual, you're going to switch sides. This is just showing the proximal surface. Again, you want to have that 2-point contact. Yeah. A periodontal file, it's important to understand, guys, these are not a standalone. So you could not just instrument an area with only a periodontal file. These always need to be followed up by another instrument, okay? This is just to help break it up, and then you're going to always follow with another instrument, okay? Okay, so this is the anterior teeth, like we said, Hirschfeld 910, and this is just showing facial and lingual. It is kind of, files are nice for like direct lingual of the upper anteriors, just because it's a lot easier to get like a strong stroke across the direct lingual of the upper anterior, because sometimes the angulation is kind of tough. So I do like files for there, and like I said, like really tenacious calculus. I love these. Okay, the next one is going to be modified Langer curettes. Okay. So the face is at a 90-degree angle to the lower shank. There's 2 cutting edges per working end. Each curette is limited to use only in certain areas, and they have a long, complex functional shank. Okay, so here's a picture of that. You can see here, cutting edge is 90 degrees. Okay, we've got the 2 cutting edges. So this is more similar to like a universal curette, where because the cutting edge is at a 90-degree angle, that both sides are going to be active. Where our Gracie curette, because the cutting edge is offset, you're only going to have 1 working end. Okay. So a Langer 5.6 is for anterior, the 1.2 is for posterior, 3.4 maxillary posterior, 17.18 posterior teeth. Okay. They do make Langer mini curettes, which are recommended for root surface debridement. And then the standard Langer curettes are designed for instrumenting 4 millimeters or less in depth. So this is just our step-by-step of the Langer miniature. So you can see they're doing the distal portion of the distal root. Now they're going to do the mesial portion of the distal root. So they're not having to change. It's basically like a universal curette with a more complex shank so that you can adapt it more easily to posterior teeth with periodontal involvement. Okay. So they're not having to switch sides like you would on a Gracie when you go to like the distal portion of the mesial root and the mesial portion of the distal root. So they're switching cutting edges, but they're not switching sides of the instrument. Okay, mesial surface of the mesial root, still the same end. Okay. The 1718 is very similar to like your 1718 Gracie, which is going to be the shank is more complex and makes it easier to position for distal surfaces and just like third molars, really posterior areas, especially with people who have limited opening, just because your instrument is already adapted. Okay, so this is just showing a miniature working end of the Langer curette. It's really great for frication areas. So like we talked about, it's used like a universal curette, and you need a set of Langer curettes to instrument the entire dentition. Okay, modified Gracie curettes. So we have two different kinds of modified Gracie curettes. We have extended shanks, which are going to be used in deeper pockets, and minis, which are going to be used in narrow pockets or like in the anteriors when there's deep pockets. Okay, so a standard area curette is ideally used in 4 millimeters or less. Modified Gracie curettes are designed for use in periodontal pockets greater than 4 millimeters. So like I talked about, all of these areas we're talking about right now, these instruments are used for people with just more advanced periodontal disease. So this is just showing the difference between a standard and an extended shank universal curette. So the lower shank of the extended curette is 3 millimeters longer. They also make extended 11-12 Explorers, and so sometimes you'll see one where like the working end is longer and then the terminal shank is longer, the lower shank. Okay, and this is just for adaptation in deeper pockets. So it just shows here how this one can get all the way to the base of the pocket while this shank is remaining parallel. Okay. Also great for like maxillary molars, getting into those furcations, deeper pockets here. Okay. Now, this one here on the far right-hand side, this is a miniature curette. So typically these are also going to have an extended shank, but the working end is mini. So it just kind of helps you in those deeper pockets stay on that end 1 to 2 millimeters and stay adapted and be able to get the calculus off. Especially like in furcation areas, like I said, in the lower anteriors or really narrow pockets, the minis are awesome. And you guys all will get a set of minis, and you'll get a mini 13-14, a mini 11-12, and a mini 1-2. And I have all of those right now. So I can give those to you this week, Wednesday. And those are instruments that were purchased by the program. So you will return those ones at the end of your time. But for right now, they are yours to use. Okay, so a miniature working end is shorter and thinner than a standard curette. This is just showing a comparison of working ends. Okay, so this is a mini in the lower anterior. Works very well on tiny roots of the mandibular anterior teeth, like I was talking about. Okay, so longer lower shank, thinner working end. Okay, this is just showing the picture. Remember when we have an offset face, then we only have one working cutting edge. When we sharpen, we're only going to be sharpening one end and then rounding the toe. Okay. Showing the mini. Okay, so modified Gracie and the micro miniature, used in special areas of difficult access. Like we talked about, 20% thinner than a standard Gracie. And this is ideal for fine deposit removal following instrumentation with other curettes. So it's like when you have just like a little piece left and you can't get it off, having a micro mini is great. Okay, this is a micro mini picture. Like we talked about, it's thinner and shorter. Okay, it's about half the size of a regular Gracie. Okay. Okay, so again, modified Gracie curettes are designed for use in periodontal pockets greater than 4 millimeters. They're thinner and have longer lower shanks. Minis have have a shorter working end and a longer shank. Okay. Okay, vision curettes. These are super cool. And honestly, before this lecture, I had never even heard of these. The vision curettes have these little bands on them that help to show you how deep you are in the pocket. The lower shank has raised bands at 5 and 10 millimeters, so 5 and 10. The bands provide a visual meaning of estimating the depth of the pocket. An identification mark plus on the handle near the junction of the shank indicates the lower cutting edge. Okay. So it's just showing you like this is the end of the instrument you're going to work. Okay. Again, we're going to have that offset cutting edge just like all of our Gracies, where only one is going to be active. And so this is just showing you like, okay, so this is 5 millimeters. If there was tissue here, it'd be 5 millimeters under the tissue. Just kind of a great visual. If you know the pocket is 7 millimeters deep, you know that you need to go past 2 millimeters past this first band. Just another view. Vision curettes are used in special areas of difficult access. And I really want to try to get some of these for the clinic. We were going to, and then we had like the huge budget crisis. But I think that these are a great tool, and I think that there should be more of this happening, even like on Cavitron tips or on the laser tips, so that you know how deep you are underneath, just because so much of the work we're doing, especially when we're doing periodontal instrumentation, is so blind. And so having that visual mark of like, oh, this is where I am in the pocket, or okay, I need to go a little bit deeper because I know that this is a 12, so I need to go 2 millimeters past that last band. I mean, ideally, we're not scaling in a 12, but sometimes we are. So having those visual marks, I think, are really helpful. Okay. So we have our quatinification curettes. The working end is a miniature hoe. Okay, and we haven't really talked about hoes a lot because they're not used really commonly. There's one straight cutting edge per working end. Cutting edge has rounded corners. So these are just furcation curettes, but you can see how it's like this cutting edge is like comes to a point and is very sharp. It's like very square. And honestly, the reason these are used in like class 2 furcations, I think personally I would rather use a mini Gracie in this area just because you have less of a chance of causing harm to the tissue and the furcation. Just because this is so bulky and like I said, like square rather than being a rounded toe. So when I'm working subgingivally, I don't like a hoe design personally. But this is just showing your adaptation. I have not seen any of these in the clinic. I've never seen them in private practice either. This is not something like I'm going to test you on, but something that if you see this on a board exam, you know that these quatinification curettes are used in furcations. Okay. Okay, so O'Hare and DeMarco debridement curettes. The working end is a tiny circular disc, and the entire circumference of the working end is a cutting edge. So just shows you this little disc. It's all a cutting edge. There's another picture of it being used in a furcation. Again, personally, I would prefer to have a Gracie here because I think your adaptation is going to be better. And again, less chance for harm in the furcation area where we can't see. But here's a picture of it. I've never seen one of these in the clinic either. Okay. Just a little recap. Okay, diamond-coated instruments. These have no cutting edges and they're coated with a very fine diamond grit. The working end is similar to a neighbor's furcation probe, and they're used like an emery board to remove small remnants of calculus. So here's a picture of it, just like a diamond coated, looks almost like a probe. And you're just like putting it into the furcation basically to smooth. So this is like, okay, let's say you were only able to get like your Cavitron and like Gracie in there a little, but it still feels rough. Very gentle strokes here. We're not using a lot of lateral pressure because it is diamond coated and we can cause damage to the root surface. So it's really quick, like couple strokes in the furcation. I haven't seen these in the clinic either because these are really common to cause harm as well. Okay. A lot of these instruments, if they're not used correctly, especially these advanced periodontal instruments that aren't used super often, if you use them incorrectly, they can cause harm. Okay. And then like distal root concavity, just showing that diamond coated instrument doing some strokes in there. They're finishing instruments after you've removed deposit. So used with very light pressure, multi-directional strokes. Ideal for use in class 3 and 4 furcation areas, okay? Okay, endoscopes. These are super cool. It's an illuminated optic instrument to view the interior of a body cavity or an organ. So they've been used for many years in medicine. And now we have dental endoscopes, which consist of a fiber optic camera covered with a disposable sterile sheath. So you basically put this like underneath the tissue and it's kind of like a video game. You're looking at the screen, you have your endoscope under the tissue to see if you missed any calculus. And this is Dental View. That's the brand that we're looking at right now. So you actually hold the endoscope with your non-dominant hand. Okay, so the clinician holds it in your non-dominant hand, and then you have the ultrasonic in your dominant hand so that you can like put the endoscope in and then go over the piece of calculus and then put the endoscope back in. Honestly, this is super hard to use. I've only used it on a Cavitron, like at a dental convention once. They're super expensive, really time consuming, and it's really hard to get used to. Not recommended for routine subgingival instrumentation because the technique for using it is too time consuming. So the ideal situation for these is for it to be used in an area that, let's say a patient comes back in 6 weeks, they had 1 7mm pocket, it's still bleeding. Okay, let's put the endoscope in there and see if we missed something. Subgingival visualization of the root surface is magnified at 20 to 40 times on the monitor screen. But yeah, it basically just helps you to see below the gingival margin, okay? And I would love if someday we could get an endoscope in the clinic, but they're super, super expensive. And like I said, they're really tough to use. And I really don't foresee any of you using them in private practice, at least in the next like 10 or 15 years. Okay. They haven't really perfected it enough for a regular dental office to have one. Okay. Advanced techniques for root instrumentation. So, anatomical features that complicate instrumentation of root surfaces. So, root concavities. We know from tooth morphology that we have, like, teeth just have natural depressions in them. So we know, like, mesial of a maxillary first premolar, distal of a maxillary canine have these depressions. And it can complicate instrumentation, especially when the roots are hidden from view in deep periodontal pockets, and especially if there's a depression on a tooth that doesn't normally have a depression, because then you don't know what you're looking for. Effective instrumentation of root surfaces require complete knowledge of root morphology. So a lot of times, guys, when I'm scaling in these deep pockets, I'm thinking, okay, what does this tooth look like? Like I said, I know this depression on a maxillary first premolar is going to go from the CEJ all the way to the furcation. And it's important to know that maxillary first premolars also have a furcation, because the other day I was scaling one and it just kept going deeper and deeper, and I'm like, what the heck am I catching on at the end? And I was in the furcation of maxillary first premolar. It's not going to happen all the time, but you are going to get into situations like that in your career for sure. A palatal groove. So we know that it's really common on a maxillary lateral to have a palatal lingual groove, where this developmental groove goes up underneath the gum tissue. And I have another picture in the next slide too. We know that proximal surfaces on a mandibular canine are going to have a deep concavity. And then it's both mesial and distal surfaces of a lower canine, okay? A wide, shallow concavity on mesial surfaces, that looks like a lower first premolar. Mesial of the mandibular molar. But a lot of times you can see this on a premolar too. And then this is proximal surface of an upper premolar. And then we know deep depression on a root trunk and furcation of a mandibular molar. So that's like your class 1 furcation. We can get this deep depression right above the furcation area, okay? And remember, the trunk is this area on a multi-rooted tooth that before it splits into two, okay? For documentation purposes, it's nice to know that. Okay, so it can happen in proximal surfaces in the furcation of a maxillary molar. And this is just showing all these green areas are concavities on a first molar. And everyone, like, we have the ones that are really common, you know, like I was saying, maxillary first premolar, maxillary canine, mandibular first molar. Those are the ones that are important to remember, but also remembering that we have anomalies all over, and you can have one on a tooth that doesn't normally have one. Here's a picture of calculus in a furcation area on a maxillary molar. So obviously super important to know our root anatomy for successful instrumentation on these areas. That way we can remove the plaque and calculus from those areas. Okay, so when we're exploring these areas, it's super important to remember these, because if we aren't properly rolling our instrument into this depression, we're going to miss calculus all the time on maxillary first premolars, okay? And I see that so commonly in like new patients that come to our office, and they've got big pieces of calculus on the upper first premolars and on the distal of the canines in these concavities, because it's important to continue to remember these things, not just right when we get out of school. So this is just showing calculus in a depression, and how if we're not properly rolled into that depression on the end 1 to 2 millimeters of our instrument, we're going to miss all that calculus, okay? And then if our explorer isn't rolled properly too, to where the working end is touching that depression, we're never going to know we missed it. This is just showing the correct technique of getting that working end into the depression. And again, same thing, they roll that toe, that end 1 to 2 millimeters into the depression to get the calculus out. Okay, both vertical and horizontal strokes should be used to explore concavities on a mesial or distal surface. Okay, vertical stroke, horizontal stroke, okay? So this is going to be like in a palm down and then in a palm up position, dragging that horizontal stroke across the maxillary first premolar. Concavities should also be explored from both the facial and the lingual. All areas should be explored from the facial and the lingual, but especially in concavities. Okay, so from the facial, from the lingual, both vertical and horizontal. Okay, exploring a mandibular molar. So we want to do the mesial portion of the distal root, the roof of the furcation area, the distal portion of the mesial root, And then the facial depression on the root trunk. So see how they explored the furcation area vertically, and then they also explore the furcation area horizontally, because again, we have that depression in the trunk right there. We want to be able to make sure that there's no calculus hiding in that trunk area of the furcation. Okay, proximal surfaces on a maxillary molar. So we're going to go into that concavity first, horizontal strokes across it, and then we go into the furcation of the palatal root. The palatal root depression, we want to have our tip up. Again, we're going to explore vertically and horizontally here. Facial depression of the root trunk. Okay, maxillary molar furcation. So this is where we know when we have a tri-rooted tooth, we have to explore both the distal and the mesial of all the roots. So right now it's doing the mesial of the distal buccal root. And then now it's going to do the distal of the mesial buccal root. And then in the furcation. And you guys, especially like an upper molar that's really furcation involved, it's tricky because you got to get all areas of the furcation. So you've got to do between the two buccal roots, between the distal buccal and the palatal, between the mesial buccal and the palatal. And a lot of times there's another tooth right next to it. So really tricky areas that just honestly, this one tooth could take you an hour to work on because there's so many areas where bacteria and that calculus can hide. There's so many depressions. And that's why, especially if I have a really deep pocket on a maxillary molar, I'm like, nope, go to the periodontist because there's so many areas that can be missed. And if we miss even one small spot, then the area can never heal, okay? Because there's always going to be that periodontal bacteria that hides on the surface of the calculus. Okay, multi-rooted teeth. And then, like I was saying, the best approach to instrument each root as a separate tooth. In other words, imagine that two roots of a mandibular molar are single roots of two premolars. Okay. We love the miniature area specific curettes when you're doing these roots. Okay. So we want to begin with the root trunk up here. We're going to do distal curette from the distofacial line angle to the distal, mesial curette from the distofacial line angle across the facial on the mesial surface. Then we want to do the root branches. So we're going to use the distal for the distal root, and then we're going to use the distal for the distal of the mesial root, and then for the mesial of the distal root, we're going to use our mesial curette. Same thing, mesial of the mesial root, we're going to use our mesial curette. Okay. So, distal portion of a distal root, we're going to use the distal curette. Distal portion of the mesial root, again, distal curette. You will have questions on your board exam about using the distal portion of a distal portion of a mesial root. Which Gracie should you use? And then it will have a distal Gracie curette, a mesial Gracie curette, a sickle, a hoe. And your answer will be you'll use the distal curette. Okay. But they like to trick you with the whole like distal portion of a mesial root. So we know that every distal portion is going to use a distal curette. Doesn't matter if it's the mesial root, or every distal portion will use a distal curette. Mesial portion of a distal root, we're going to use a mesial curette. And then in the furcation area, also this will still be a mesial curette. Mesial portion of the mesial root, mesial curette. Okay? We want to just treat each root as a separate tooth. We're going to use horizontal, vertical, oblique strokes to properly root plane those areas. Okay. So we've talked about horizontal instrumentation strokes to remove deposits. Vertical strokes are not effective because the working end often spans across the root concavity, missing the deposit. So vertical strokes, this is showing Gracie 11 to make vertical strokes on the mesial surface. And then it cannot be used to make a horizontal stroke as the lower cutting edge does not adapt to the mesial surface. So this is where you use the back side of your, so you'll use the distal portion to do the mesial surface of a lower molar and do a horizontal stroke. And these are things that, like, you've probably seen your instructors do so far, especially like distal of a lower molar. I'll use either the opposite end of my universal curette or the opposite end that I should be using of my Gracie in order to make a horizontal stroke across the distal, okay? And as you guys get into more advanced patients and we get more comfortable, we're going to show you these things because now a lot of you are seeing more difficult patients where you do need to make a horizontal stroke again across the back of a lower molar to get stuff off, or you need to use the other end of your curette in order to make a horizontal stroke and get the calculus out of that root depression. Okay, the correct working end to make a vertical stroke on the mesial surface is not the correct end to make a horizontal stroke on the same surface. So this is what we were saying, that on a Gracie 11-12, our normal working end for the mesial surface would be the 11, right? But to make a vertical stroke, yes. To make a horizontal stroke, we're going to flip our instrument, use the other side so that the blade is at proper angulation to get into that depression. Okay, and this is just really wordy, and I don't even want to go into this because it's just gonna confuse you. It's just, you can use the opposite side of your Gracie to make a horizontal stroke, okay? And then horizontal strokes on the facial or lingual, this is, you'll use the normal, whatever surface you would normally use. So if you're on the facial of a lower molar like they are here, this would be your 11 end of your Gracie, the normal surface normal end you'd use to instrument the mesial of a lower molar. And all you're going to do is just lay your instrument down to where that terminal shank is almost perpendicular to the tooth, and just make a horizontal stroke across the facial and the trunk. Okay? So we'll use the same working end to make both vertical and horizontal strokes on the facial and lingual surfaces, which, remember, horizontal strokes on the mesial and distal surfaces, you're going to use a different end than vertical strokes, okay? Good. Good. Advanced fulcruming. So I know you guys have already talked about this a little bit with Miss Larson, and we've talked about using extraoral fulcrums and advanced fulcrums. And this is just, as we get into these more advanced periodontal patients, you guys are going to need to use advanced fulcrums, okay? It's always the standard that if we can use an intraoral fulcrum, it's the best. But if not, then we need to use our advanced practices. But advanced fulcrums are not intended to replace standard intraoral fulcrums. Standard intraoral fulcrums are going to be the least amount of strain for you, and it's going to be the safest option, especially when you're making really strong strokes in a root planing situation. But poor skills and bad habits in using standard intraoral fulcrums cannot be corrected by the use of an advanced fulcrum. So that's why we've really been wanting you guys to work on your intraoral fulcrums before we do more advanced fulcruming. Okay. Like we talked about, you should master the intraoral fulcrum before trying to go to advanced fulcruming techniques. And then areas with limited access is where we want to use them. So working in a narrow, deep pocket or in a crazy furcation, that's when we want to use these. Okay, so we have a modified intraoral fulcrum where with an altered point of contact between the middle and the ring finger in the grasp. Okay, so basically this is just like you're further away from your working or the area that you're working on. Okay, it's not the same as a split fulcrum where the ring finger does not touch the middle finger. Here's the point of contact is lower against the middle finger. So basically it's just like your hand is a little bit more spread apart because you're working further from your working area. Okay, normally we'd want to be 1 to 3 teeth, but this is more like 4 to 5 teeth away. And I feel like most of you guys have probably already been doing this. Okay, the cross arch fulcrum, where you're fulcruming on the maxilla and working on the mandible, or vice versa. Okay, or I'm sorry, cross arches, you're on the opposite side of an arch from the treatment area. Sorry. So cross arch intraoral finger rest is on the opposite side. So let's say you're working on number 30, you're going to fulcrum on the side of like number 19. Okay, so you're on the opposite side of the arch, cross arch. Okay. Opposite arch fulcrum, this is where I was saying you're going to fulcrum on the lower, work on the upper. Fulcrum on the upper, work on the lower. Okay. Finger on finger. So this is where your finger of your non-dominant hand serves as a resting point for the dominant hand. This one I used a lot when I worked at Holly McCullough and did outreach stuff, because sometimes my patients were like their jaw was shaky, and so I needed to have something that was stronger to fulcrum on, or they moved a lot. I use this on kids. If they're missing teeth, I'll use this so that I can have something strong to fulcrum on, okay? Again, this is just showing a picture of that. Use your own finger as a fulcrum. Just another picture of it. Okay, extraoral fulcrums. I'm not going to go over that again. We already have been over it a lot of times. If we can, we like to use an intraoral fulcrum. We can't always do that. So typically you're going to be grasping a little further away from the working end. So you're going to be like choked down on your instrument a little bit. And you can see that this one, she's resting against the patient's chin in order to get to the upper right. So again, someone has like limited opening, or you're trying to get to the distal of a maxillary molar, you're probably going to need to use an extraoral fulcrum. Okay, so you can see the knuckle rest technique with the basic extraoral fulcrum. Palm is facing out, so you're using the knuckle of the pointer, middle, and ring finger to kind of fulcrum against, okay? Palm up. This is a left-handed clinician. Okay, here's another one. This is like a chin cup. So usually you're going to use this on the opposite side of whatever you're dominant. So if you're working on the left side, you'll use this to work on, if you're right-handed, you'll use this to work on the left side. Okay? This is just showing left-handed clinician how they're doing the chin cup for working on the upper right-hand side. Okay? Finger assist. So finger of the non-dominant hand is used to concentrate lateral pressure against the shank of an instrument. I use this a lot with files, and also just when I have really tricky, like tough calculus. I'll use my own finger to put a little bit more lateral pressure. That way my dominant hand doesn't get so tired from scaling, especially when I'm, like I said, when I'm working on a patient with really tenacious calculus and I'm doing 2 quads of scaling, like my hand will get so tired. So I'll use a finger assist in order to help me get lateral pressure. Okay, so this is just showing again, a right-handed clinician uses the left index finger to apply pressure. I don't know if I already said this, but I use it a lot with files too. I'll use a finger assist. Just another picture of it. This is a right-handed clinician. Again, putting pressure on the back of the instrument to get some lateral pressure. Especially when you're using an extraoral fulcrum, it's a little bit harder to put as much lateral pressure. So using the other hand also helps to like stabilize you too. Okay. So many pictures of the same thing, sorry. Okay, so again, we want to use these selectively when it's appropriate, okay? Not replacing our regular fulcrums. Alrighty, and we are going to go to our last one, which is going to be chapter 30. And a lot of this is going to be review, so I'm just going to kind of fly through this from that last one. Root morphology, I just have some good pictures in this one, so I wanted to show you this. So also super important, guys, to remember the CEJ. Practicing feeling the CEJ. We know that it's something that's going to be within a millimeter of the gingival margin if the patient does not have any recession. And it's something that as we get more practice with scaling, we're able to feel the difference between CEJ and calculus, okay? So anatomic root is part of dentin covered by cementum embedded in the alveolar bone. We have our root apex, that's the end of the root. The peri-apex, that's the area surrounding the apex. The root trunk, which is teeth with 2 or 3 roots, have this unbranched portion, which I showed you in the last. It's the area between the crown and where the roots split. That's the trunk. The furcation roof is the most coronal portion of the furcation. Then the clinical crown is the unattached portion of the tooth. Okay. Talked about the CEJ. Excuse me. Subgingival identification of the CEJ is competency that requires knowledge of root anatomy, development of tactile skill, and ultimately just experience too. That's going to help you guys with identifying the CEJ. Enamel is, different textures of the structures of teeth. Enamel is comparable to glazed pottery. It's smooth, hard, and glassy when unaltered. Cementum is more porous. Remember, cementum looks almost kind of like fine-grained sandpaper underneath a microscope. But cementum can be altered by periodontal attachment, biofilm byproducts, or unintentional injury by patient or clinician. So sometimes patients can have like root gouging where somebody has overscaled an area. So that's why it's super important that we're picking up our Explorer and making sure we're not overscaling an area, because we can cause root damage. So we know teeth with 1 root are more conical in shape. The cervical cross-section is usually triangular, ovoid, or elliptic. And in most sections, root shapes are generally the same as in cervical sections. Teeth with 2 or more roots, so we have maxillary first premolars, maxillary molars, mandibular molars. Maxillary mandibular molar roots in cervical cross-section are larger and have more variation in appearance, okay? So furcations generally begin as a shallow depression on the root trunk. So like this area right here where our instrument can kind of just feel in there a little bit. We can feel a dip. Gradually opens into a space between the roots. The more cervical the furcation is, the more stable the tooth. Meaning like a class 1 furcation is more stable than a class 2, 3, or 4, okay? Furcations on mandibular 2nd and 3rd molars are slightly more apical than the first molars. So if our gingival margin is the same for, let's say, both number 30 and 31 have 2 millimeters of recession, this area, the tissue is pulled back, but, and this is the alveolar bone right here. This is like a periodontal flap surgery happening here. But typically if you have recession, that's the same on number 30 and 31. Number 30 will probably have some furcation involvement where 31 may not, meaning just the trunk is a little longer. It doesn't bifurcate as close to the crown as a first molar does. So the most common area where you're going to see furcation involvement is probably a mandibular first molar. We talked about root concavities a lot. Maxillary first premolars have a mesial concavity extending from the CEJ to the furcation. Important that we do horizontal strokes in these areas and that our instruments are adapted properly to get all the way into the depression. Tooth alignment is another big thing. I'm sure you guys have noticed when you have patients with like mandibular anterior crowding, it's a lot harder to properly instrument those areas because sometimes like the contact is really long and a lot of the tooth is touching. It's hard for the patient to clean and it's really tough for us to access too. But always being an assessment of these areas is essential to adapting our instruments and knowing what we need for each patient. Like for people with crowding, we're going to want to have our purple ultrasonic. We're going to want to have a nice sharp posterior sickle to get up underneath the contact in those mandibular anterior areas, okay? Fused roots and concrescence. So molar roots can be fused together, especially in the second and third molars. Fusion is two tooth buds fused together during development and form one large tooth. Concrescence, this is when two adjacent teeth become joined by cementum. So this picture here is concrescence because they're only joined by cementum, okay? Remember fusion, it comes out and just looks like one big tooth. Okay. Accessory roots, this is really common to see just extra roots. And typically if someone has accessory roots in one area, like let's say they have trifurcated lower molars, they probably have like bifurcated lower premolars and extra roots in all areas, okay? But it's important to know that using our radiographs to be evaluating that. So if you're like, what am I feeling here? That you know, like, oh, this area is trifurcated, okay? Palato-gingival grooves. So we talked about this in the last PowerPoint, but this is just a really great picture of sometimes like we talked about, the maxillary lateral can have all of a sudden you sink into a 7 on the direct lingual. It's probably going to be caused by this palato-lingual or palato-gingival groove, okay? It's highly biofilm retentive, so can cause perio problems and caries problem in here, okay? Susceptible to gum disease. Hypercementosis, this is really common too. It's excessive formation of cementum in the apical third or half of the root after a tooth has erupted. Usually it's caused by trauma, chronic inflammation of the pulp, or metabolic disturbances, and it's assessed radiographically. So you can see in this radiograph here, we have this like big chunk of just extra cementum growth, okay? Okay, so cervical enamel projections, or CEPs, are apical extensions of CEJ towards the furcation of a molar. So they're classified by degree of extension. We have a grade 1, which slightly extends towards the furcation. That occurs frequently. We have a grade 2, which approaches the area of root separation. A grade 3 extends into the furcation, and a grade 4 is the same as a grade 3 plus furcation is visible, okay? Periodontal attachment loss is more likely in areas of cervical enamel projections because the periodontal fibers do not form the same type of attachment to the enamel as they do to the cementum, okay? So enamel pearls and dilaceration. Enamel pearls are they're misplaced enamel. So it's not on the enamel, but it's on the cementum, okay? So these are also going to be visible on a radiograph. Dilaceration is a sharp bend in the root surface caused by displacement of the root during tooth development, okay? So where we get this big like right angle formed in the tooth. So it's important to document these areas, especially if like you find an area like of a possible palato-gingival groove and you refer to the periodontist, or you're like, oh, we know number 15 has an enamel pearl on the distal. Document that so that clinicians in future are able to know. And also it's like if we have an FMX and we know that number 20 has big dilaceration and we refer them to endo, how great is endo going to be able to do their job? You know what I'm saying? It's just being able to know what we have going on in our patient's mouth is really important for documentation. Okay? All right, guys, that is it for today. I'm going to have your midterm ready for you to pick up after you view this. And it's going to be take-home midterm exam. So if you have any questions, feel free to shoot me an email, just as always.